Now, it gives me great pleasure to introduce our panelists and our moderator for today's luncheon. More details about their individual backgrounds and achievements can be found in your program. Here are the highlights. Dr. Karen Swartz is the founder and chief of faculty for ADAP, the Adolescent Depression Awareness Program. An expert in the field of mood disorders, Dr. Swartz is an associate professor in the Department of Psychiatry and Behavioral Sciences, is the director of clinical and educational programs at the Johns Hopkins Mood Disorder Center, and is the co-director of the Women's Mood Disorder Center. Dr. Swartz is a pioneer in breaking the stigma of bipolar disorder through education and awareness. Would Dr. Swartz please join me and take her seat on the panel? Dr. Randy Buckner is professor of psychology and neuroscience at Harvard University, director of psychiatric neuroimaging research at the Massachusetts General Hospital, and an investigator at the Howard Hughes Medical Institute. A much sought-after expert with hundreds of scientific papers to his credit, he has been invited to speak all over the world about his work in cognitive neuroscience and brain mapping. Would Dr. Buckner please take his seat on the panel? Dr. K. Redfield Jamison is the Dalio Family Professor in Mood Disorders, Professor of Psychiatry at the Johns Hopkins University School of Medicine, and co-director of the Johns Hopkins Mood Disorders Center. She is also Honorary Professor of English at the University of St. Andrews in Scotland. She is the co-author of the Standard Medical Text on Bipolar Illness and author of Touched with Fire, a copy of which is in your gift bag today, An Unquiet Mind, Night Falls Fast, Exuberance, and Nothing Was the Same. Dr. Jamison has written more than 125 scientific and clinical articles about mood disorders, suicide, creativity, and lithium. Her memoir, An Unquiet Mind, which chronicles her own experience with manic depressive illness, was on the New York Times bestseller list for 5 months, has been translated into 25 languages, and has sold well over 1 million copies. Dr. Jamison is the recipient of numerous national and international literary and scientific prizes, including the Lewis Thomas Prize and the MacArthur Genius Award. Would Dr. Jamison please take her seat on the panel? Amy Morrow has devoted her life to her family, her career, and her community, and in the process has traveled the world. After college, she and her husband, Bill Morrow, moved to Chicago and soon thereafter began their world travels. First, Amy and Bill lived in Brazil while Bill worked on the JARI project. From there, they moved to Sydney, Australia, then to San Francisco, and finally back to Chicago to raise their 3 children, Anna, James, and Will. An avid and competitive sportswoman who skis, plays tennis, and swims, she began a career in real estate after her children were in college. Amy has supported the Ryan Licht Bipolar Foundation from its first Chicago Medical Briefing Luncheon and has represented the foundation at the National Institute of Mental Health and at the foundation's Pediatric Bipolar Disorder Conference at Harvard. Amy was the recipient of the foundation's 2014 Chicago Shining Star Award. Amy is the mother of a son with bipolar disorder and will share her family's story with you today. Would Amy Morrow please take her seat on the panel? And our moderator is Dr. Ellen Frank. Dr. Frank is one of the true luminaries in the field. She is the director of the Depression and Manic Depression Prevention Program at the Western Psychiatric Institute and Clinic of the University of Pittsburgh Medical Center and is an expert in mood disorders and their treatments. She served on the Mood Disorders Work Group of the American Psychiatric Association Task Force on the DSM-5 and was chair of the Food and Drug Administration's Psychopharmacological Drugs Advisory Panel, is an honorary fellow of the American Psychiatric Association, and was elected to the National Academy of Sciences Institute of Medicine in 1999. And we are also fortunate to have Dr. Frank's husband, Dr. David Kupfer, the task force chairman of the DSM-5 project, a world-renowned psychiatrist, and a panelist at last year's Palm Beach Luncheon in our audience today. And now it gives me great pleasure to ask Dr. Frank to please come to the podium and take over the program. Thank you.
So, as someone who has devoted the last 30 years of her life to finding better treatments for bipolar disorder, it would be hard to fully express how meaningful it is to see this gathering today and to think about what the Ryan Licht Sang Foundation has accomplished in its relatively short life. It's also important that I express how grateful I am to Joyce and Dusty for having the confidence in me to wrestle this crowd into the brief time that we have to listen to their very, very important thoughts about bipolar disorder. You've heard who all our panelists are, so I won't reintroduce them. But what I will do is just a little bit of housekeeping. As you heard, we will have a question and answer session as soon as all of the formal presentations are completed. We ask, please, that you wait until a microphone is brought to you to ask your question, because as gorgeous as this room is, the acoustics are not the best without a microphone. So please, as you're ready to ask your question, do wait for someone to bring you a microphone. We will conclude promptly at 1:30 for those of you who do have other obligations, and then we'll spend another 10 or 15 minutes taking additional questions after those who must leave have left. So I understood that it's Randy who's going first, but you're seated in the wrong order. So Karen, I guess it must be you. All right. Karen is going to talk, I assume, about the wonderful work that she has done with high school students who might be at risk for or who have bipolar disorder. Karen, it's a pleasure.
Thank you. Well, first, I want to add my thanks and gratitude to Joyce and Dusty for their leadership in this area. It's really remarkable. And if you know them, you know that they just inspire you to do more. And I think that's what they do for all of us. And I also wanted to acknowledge Micah Ford and Christian Ray, because as the chairs of the junior committee, their work quite specifically is supporting our expansion of ADAP into the schools in Palm Beach, which is terrific. My task this afternoon, I guess we're getting to. Technology is letting me down a little bit here. There we go. Is to talk about early onset bipolar disorder. Typically, bipolar disorder will start late teens, early 20s, but there are a group of young people that have the onset of this disorder even earlier, and it is a real challenge. And so I'm going to hopefully, in 8 minutes, make that come alive for all of you. So let's just start with what bipolar disorder is. It's a remarkably challenging illness because you have a medical illness that literally changes your mood, physical symptoms, how you feel about yourself, how you behave, how you interact with others. And in doing it, there's nothing that we can yet measure. So we can't take your blood pressure, we can't do a blood sugar to say you have it and it's really bad today or this is different. And this is all happening with young people who have the challenge of separating from family, becoming more independent, so maybe they're a little challenging anyway. And so with bipolar disorder, you have both periods of depression and periods of mania. Let me describe first what it's like for someone when they're going through depression, other than saying that it's truly awful. So you have changes in mood, and that manifests in someone not feeling themselves and not being able to feel joy in the way they normally would. But it also means for teenagers that they're usually irritable. And when I talk to parents, they often say, well, teenagers are often irritable. That's just true. How do I tell the difference? I said, well, you're not talking about your teenager being irritable with you when you have said you cannot have the car. You're talking about teenagers being irritable with their best friend, with their favorite coach, and with their teachers. So it's something that really pervades all through someone's life. They are less likely to have the sad crying form of depression that you might see in a Lifetime TV movie. That is what middle-aged women typically have. I say as a middle-aged woman, but the truth is for teenagers, it's much more challenging because they're irritable and they feel negative about things. And they're not sleeping. They're waking up through the night. Their appetite's off. Their concentration's off. They're not doing as well in school. So there are all these other physical symptoms that come along with it. And then probably most importantly and most seriously, it changes how they feel about themselves. People lose their confidence. They lose their belief in their future. And in the most serious sense, they can think that their life's not worth living. So it is an illness that literally robs you of your sense of yourself. And that's in this sort of negative, terrible way of depression. And then with mania, it's the exact opposite in so many ways. Things are over the top. Dr. Jamison wrote about this beautifully in her book entitled Exuberance. That says everything. You're over the top, you have energy, you are talking a mile a minute, you have a million ideas, you have confidence that will get you in trouble because you don't think anything could go wrong. And often people are risk-taking and taking chances that they wouldn't normally do. Obviously with depression, the great worry is someone will harm themselves. With mania, you have created chaos for everyone around you. Spending money, doing uncharacteristic things, doing dangerous things. And that's sort of the classic. And the classic bipolar, you're seeing these high, exuberant, fun manias and low periods of depression. But with young people with early onset bipolar disorder, they have something different. They have irritability that's also in the up phase. They don't really have that fun mania that often gets depicted in movies. They are irritable. They are having temper tantrums. They are out of control with crying outbursts. They are having anxiety, whether it's separation from family or generalized feelings of anxiety, or whether it's social anxiety. They don't want to interact with friends. They feel less confident in those situations than they used to. And they're often dropping out of their usual activities. Someone that played soccer for 10 years saying, I don't want to do it anymore. Someone who loves dramatics not going out to participate in the school play. And so an isolation and limiting the scope of someone's world. And the school nurses often know the young people suffering from this because they have lots of headaches and stomach aches. And what they're really saying is, my body doesn't feel right. I just don't feel right. But we don't know enough about this illness, and the general public doesn't know enough about this illness, and so often with young people these symptoms are missed. They'll be appropriately identified perhaps as having ADHD, but unfortunately having ADHD doesn't protect you from developing bipolar disorder. So they can co-occur. And you think, well, we know what's going on, we're already taking care of that, and you're missing something that's new. And probably one of the big risks is that untreated, unrecognized, undiagnosed, a lot of chaos can happen. And young people often will try to find something to feel different. And it's not very hard if you're a school-age person in this country to find alcohol or drugs. And so you put some at risk of actually getting involved with those in a way that they might not have if they didn't have the challenge of bipolar disorder. So what happens if you don't do anything about it? There was a very interesting study I'd like to share with you done in New Zealand. It was done by sociologists, so they weren't doing treatment. What they were doing is every 5 years going back and seeing a cohort, a group of young people since birth. So they knew a lot about them, they knew about their IQ, they knew about what their trajectory in life was. And they interviewed them all when they were teenagers, and they came back when they were in their 20s. And they said, we're going to compare the group that had depression as teens to the group that did not. And what they found is that the teenagers with depression, almost all of whom received no treatment, they were much more likely to be addicted to substances, to have had mood and anxiety disorders, to have made suicide attempts, to not have gone as far in school as would have been expected. Because they could predict from IQ and previous, you expect this person to graduate from high school, go to college, go off to graduate school, to not have a job, to either father a child or have a child at a very young age. These are not the outcomes that any of us want for young people we care about. Amy Morrow is going to speak, I know, very eloquently about her own family's experience. I just thought I would touch on some of the experiences that families have. And this comes out of, again, often parents not knowing what's going on. So what happens? They get frustrated. Someone who is going through bipolar symptoms is not easy to be around. That doesn't change how much you love them or how much you care about them, but it's challenging. So parents get frustrated, they get worried, they get exhausted. And that child who's having challenges is often the person they have to focus on. So that's very difficult for the other siblings. They get frustrated, they get angry, and they have this sense of, why does that person, why does my brother always get all the attention? I'm doing the right thing and he gets all the attention. So you end up with these really difficult family dynamics and conflict in the family, often fueled by the fact that people don't quite know what's happening. If you could say, your brother has a medical illness, we're getting treatment for it, and we're expecting things to get better, that's a very different thing to say to a sibling than, I don't know what's going on. I agree he's being really difficult right now. But I want to end this on a very positive note. I love what I do. I love going around and teaching teachers about depression so they can teach high school students about depression, because when kids get into treatment, they get better. And that's what we're going to hear from this first person account. So what happens if you recognize this illness much earlier and you actually get treatment earlier? Well, the first thing is that you don't have the 8 to 10 years of chaos that many people have. A recent national survey showed that it was 8 years on average from the onset of depression to getting treatment, and 6 years from the onset of bipolar disorder to getting treatment. Now, people will say that just can't be possible. And I'll say, well, what happens is it's episodic. You're ill, then you're better. You're ill, then you're better. So what you don't want to do is have someone defining themselves by how they are when they're ill rather than how they are. And I think the most important thing we want to do is minimize dysfunction and allow people to thrive. You're going to hear from Kay Jamison. I don't think you could meet anyone in your life that would allow you to see how remarkable people with bipolar disorder can be. So people can thrive. Thank you very much.
Well, now Randy is going to show you how far we've come. The leap from Sumeria to the cell phone is not unrelated to what we're going to see, because without the power of supercomputing, there would be no way that we could see into the brain in the way we can right now. And Randy's going to show you some of the most gorgeous pictures you're likely to see anytime soon of our brains. Randy?
Well, thank you. And while we wait for the first slide to come up, I'd like to also add my thanks and appreciation to Joyce and Dusty and everybody here, because I think as a community we all contribute in different ways to solving these challenges that we face. Mental illness and bipolar illness, there are a few families that are unaffected. Stigma is something that we're always combating, and so just coming here today and all talking about these illnesses and making them more visible is one of the most important things we can do. And on the first slide, do I have the first slide? Our work and the work in our area of the field has been an attempt to make the invisible visible. We've known for a long time that bipolar illness is an illness of the brain. The genetic contributions are strong, but we haven't been able to see it. And this has made it difficult for us to study illness, to detect it at the earliest stages, to potentially detect the antecedents of illness before there are symptoms. And this might be the ideal place that we would target with therapies. And so what we've seen over the last several years is a number of approaches and strategies for making these previously invisible aspects of our brain come to the forefront. And what you're seeing on the screen here is actually an image that can now be made in about 12 minutes on MRI scanners that are available in many hospitals of the broad connections that span across your brain. And these connections, many of them, are what connects the motor circuits in your brain to allow your arms and your legs to move. Other circuits allow this very large structure. The human has the largest brain of all mammals for our body size that allows these different parts of our brain to talk together. And what is also embedded in this very complex connectivity matrix that all of us possess are connections between our cognitive systems, our control systems, that allow us to, in very controlled manners, guide ourselves through the world, and are also our emotional systems, which are what motivate us to move through the world. All of us have these systems. They're working together and competing and battling each other. And this is something that's good. This is something that evolution has found to allow us to move through the world, to navigate the world, to drive towards things that are good for us, to move away from things that are bad for us. And the regulation of this is from very complex distributed networks and how they battle out in any situation or over time in an individual. Now, what we now know is that these battles can go awry in individuals. And sometimes when these brain circuits aren't working together, we get illness. And we're starting to develop tools to be able to see those circuits in the individual brain. And so just in a few minutes, I want to illustrate some of the main findings and also some of the challenges. We now know a lot about the key brain systems for emotion. And one of the key systems is buried there in the middle of the MRI image that you're seeing to your left. That's called the amygdala. And this is an emotional system that drives you when you see a fearful bear attacking. This is the system that tells you run. When you see a fearful face, this is a system that's triggered, and it can be triggered in very automatic ways. You don't even have to know necessarily that you saw a fearful face to actually elicit a response in your amygdala. Now, we also know that there are other systems in the brain. I'm going to go ahead one. There are other systems in the brain that interact and control these emotional systems, and they're located in structures in the frontal cortex here in this part of your brain, but also buried deep in what we refer to as the cingulate. These structures are connected to each other, and we think inhibit each other and regulate each other. And the reason why these systems are effective is because these emotional circuits can drive our behaviors, and these other circuits can control them. And these circuits get out of balance in illness. The way I like to think of this is just a broad model, as shown on the next slide. Can I have the next slide? It's marked by this picture of Napoleon going into battle. And a horse is controlled in the same way. The stirrups drive the horse into the battle, but you wouldn't want a horse just driven by stirrups. You also have the reins that you can pull back, control, and steer that horse. And I like this image because it conveys such power. And I think our emotional systems are exactly that. They're what drives us. They're what allows us to navigate the world, and this is good. And I want to stress that. These are systems we want. But without the reins and the stirrups working together, we can become ill. Now, the striking thing that we've learned as we've made these different systems become visible in the brain is how much they affect all of us and how much variability there is. And so the image I'm showing behind me is just 1,000 individuals, college-age students, that we brought in and we imaged. And these are not individuals with illness. This is just typical variation where you see some individuals who are more emotional, might have more anxiety. Other individuals are less emotional, more laid back. There are actually good aspects of all of these traits. We consider all of these individuals unaffected. But if you look, you can already see that the differences that convey these personality styles are marked in the brain. You see larger amygdala in individuals who are more anxious and emotional. You also see thinning in the prefrontal cortex. These are highly productive individuals. In many studies, you can see that these traits are actually highly effective and cause one to navigate the world in very precise ways. But the important point I want you to take away from this is that these are changes that are already instantiated in the brain in all of us by the time we're 18 or 20 years old. If you now turn to illness, you can see that these systems are more disrupted. The regulation is more unbalanced at early stages in bipolar illness. And in children and teens with bipolar illness, at a group level, we can see that these systems that are normally imbalanced are out of balance. Now, the challenge we have is going into the individual and being able to make these measurements in a way that would be clinically useful for diagnosis and treatment. And just to illustrate to you why it's such a challenging task, I have a little movie here. And this movie is just showing a little region of the brain that I'm moving around, and you can see it, it's that little dot that's moving around, and all of the connections to that dot as it moves from one part of the brain to the other, just nearby areas of the brain. The brain is a highly interconnected set of networks. Even as you move from one part of the brain just a little bit over, you'll find there's a completely different network next to it. And these networks are interacting, and it's through those interactions that all of the things that we can do happen. And it's not surprising in that sense that the balance can be lost and these interactions become faulty. But as you see, the complexity is that seed moved around. It's actually a challenge. As mentioned, that you might need supercomputers. We do need supercomputers. The kind of analyses we do to dissect and understand these interactions take tremendous computational power, and we need to reduce this in simple ways to actually see the kinds of disturbances to these interactions in these networks that are most critical to bipolar illness. And just to give you a hint of what that might look like, and these are early days in this research, here are 3 networks, major networks that all of us have in our brains. These are networks that help us attend to the outside world. These are networks that help us think to ourselves, and they're also networks that interact with each other and compete. If you look at these networks and you make an image of how all the different parts of the brains in these networks interact with each other in unaffected individuals, as shown on the next slide, you can see this image below. This is what we refer to as a network plot. This is just an image of these interacting systems, but what I want to draw your attention to is how separate and distinct they are. One system is in red, another in yellow, and another in green. While they're interacting, those lines display those interactions, they're separate. And this is a system that's effectively regulating and distinguishing across these different networks. What we see in affected individuals is, okay, one slide back. What we see in affected individuals is that these network interactions break down and they bleed to some extent one into another. This is an individual who's in an acute stage of psychosis. And so we do not yet understand why these network interactions break down, but we have the first tools that are able to peer in and make these previously invisible interactions visible. And what the next thing we need to do as a field, and this is our laboratory, but I think all laboratories as shown on the next slide, is now move this to the level of the individual. Everything I've shown you, and most of the research that you'll hear about in the news, and there's actually a piece that's on the front page of many papers today talking about how you can use imaging approaches to see and predict illness, or see and predict who might have difficulties, for example, with reading at a very young age. All of these approaches work at the level of groups. I think this is a monumental leap forward. We can see illness in the brain. We can see that these are the biological origins of illness, but we don't have methods yet to peer into the brain of an individual where the clinical question is and see these networks and predict an individual. And I think the field is moving quickly to develop methods to target each of us individually. Thank you.
Thank you, Andy, for making something that is so complicated, so accessible to all of us here today. How many of you have heard Kay Jamison speak? Well, there is a very big group of people who are in for an incredible treat. Kay Jamison speaks with greater passion, greater eloquence, and greater clarity about bipolar disorder than anyone I have ever known. Today she's going to speak particularly about the connection between this illness and creativity and the ways in which the brains of individuals with bipolar disorder may be completely unique in ways that are entirely positive. Okay?
Thank you. Very important research that Randy's doing. I hesitate to think what my brain and the brains of many people who have this illness would look like. Presumably they're all different colors and squiggling all over the place. I'm delighted to be here. I think it's an uneventful life that doesn't carry with it suffering. And I think what Joyce and Dusty have brought from tragedy is quite remarkable. And I give them my heart for doing it. This afternoon I'm going to be talking about mood disorders and creativity. That's a slide put together by my husband, who's a professor of medicine at Hopkins, but he tends to insinuate his way into my slides. And he loves old books, and the drawing of the brain is actually done by Christopher Wren, who is the architect, of course, of St. Paul's Cathedral. It's a quite beautiful brain that vaults up really quite literally like the cathedral. And then the painting, of course, is by Vincent van Gogh. He did it not that long before he died, before he killed himself. and he did it for the nursery of his young nephew. I want to start with a huge caveat that I'm going to be talking about something very positive, and it's an association between, quote, madness and creativity and mood disorders that's been observed for thousands and thousands of years, which doesn't make it right, but it does make it interesting. And I think in the last 20 years has been well demonstrated in many large studies that there is a very much elevated rate, particularly of bipolar disorder, in highly created populations of particularly writers, but also painters and musicians. This is a poet that I'm writing a book about at the moment, Robert Lowell, one of the great poets of the American poets of the 20th century, who suffered from a very bad form of bipolar illness, was hospitalized about 20 times for acute mania, a very severe form of mania at that. And he described his manic episodes as a magical orange grove and a nightmare. And so we're talking about the orange grove a little bit today, but I want to make it very clear that there's not meant in any way to romanticize a bad illness. I've had this illness since I first had a psychotic break when I was 17 years old, a senior in high school. My family's riddled with it, many, many friends and patients. There's nothing romantic or wonderful about this illness, but it is associated, I think, with very interesting things. So that's what I'll be talking about today. What I'd like to do is just start by describing a few studies, summaries of studies, and then a few recent studies showing this link, and then talking a little bit about why this link might occur and what the implications are. This is an hour talk. I have a tendency to talk too fast anyway, so I will try and not speed too much along, but get through it. This is a summary of several of the studies, early studies looking at mood disorders and creativity, and looking at artists and writers, populations of artists and writers, and seeing what the rates of mania and depression were. If you look at the left of the slide, you can see the expected rate of these disorders in the general population, about 1% for the more classic form of bipolar illness, and 15 to 20%, depending on how you look at it and who you're studying, for an episode of major depression. It's interesting in the sense that most of these studies are done on men, and therefore it's even more striking that the elevation is so significant in depression in men, since men have half the rate of depression. But you can see, particularly in poets, time and again, the highest rate of bipolar illness. Also very high, very elevated suicide rates in writers and artists. And again, if you look at the population rate, 1 in 100 of us will die by suicide. And you can see here in the studies that have been done, greatly increased rates. Let me turn to some of the larger studies. Those are studies of relatively smaller populations. The first one was done of about 20,000 people. And what they found is in the group of people who had bipolar disorder, a disproportionate rate of creative occupations. And this is a finding that you will see over and over again. A study of about 300,000. You have to appreciate in psychiatry, you know, these numbers are big, okay? So when you're talking about 300,000 and there'll be a study later on of 1 million people, these are entire population studies of, for example, bipolar illness in Sweden. So in this case, again, you will find two interesting things. One, again, a very much elevated rate of bipolar disorder in patients with, in people with creative occupations, but you also find a very much elevated rate in their first-degree relatives. And one of the questions has always been, why should there be an elevated rate of, why should this illness continue to exist? It's a devastating illness. Why should it continue to exist in the gene pool? And there's always been the argument that it had some evolutionary advantage, that it survived for some reason. And what you see here is a partial argument for that the people who are less sick, the first-degree relatives, in other words, parents, siblings of people with bipolar illness, are also much more likely to be in creative professions. And in those studies that have looked at actual creativity, the same finding. Another study that was a kind of following kids 10 years out from taking examinations in high school in Sweden and looking at what happened to them, psychiatrically speaking, 10 years followed up. And what they found was that those students who had the highest scores in music and in Swedish, which would be our equivalent, of course, of English or language, had 4 times the rate of bipolar illness when you followed them out, had been hospitalized at 4 times the rate. What you also found was that there was a disproportionate rate of people who had not achieved and who did poorly. So it's one of those interesting examples where you have a subgroup of people with bipolar illness who do exceedingly well, and a subgroup of people with bipolar illness who do disproportionately not so well. And then this is another study looking at the similar sort of phenomenon and finding, just looking at IQ testing, the same sort of finding that people who had people who had bipolar illness were disproportionately likely to have high IQs and low IQs. So the question is, what does this mean? What might account for this? Why might this association be true? And I think, at least in the studies of mania that have been done, and this is going to be a place where obviously studies like imaging are going to be very powerful and are just beginning to be done, is that the brain is just a very different place when you're manic. It's a high voltage, high activity, fluent, and particularly verbally fluent, and lots of associations. So if I gave you a test that said, tell me as many words as you can think of to the word daisy, I could score you on the number of responses in 2 minutes, the total number of responses to daisy, and I could score you on the total number of original responses to daisy. And what you find is that when people are mildly manic, they have 3 times as many total associations and 3 times as many original associations. This is just a kind of almost metaphoric for a lot of what goes on in the fluency of the brain. But there are also non-cognitive aspects, and I would say, I was struck when Dusty said that he and Joyce were not inordinately patient. I think patience is a greatly overrated trait. People who are patient get certain things done, and people who are not patient get other things done. And one of the things that we know about people when they're manic is patience is not their middle name. They have a lot of increased energy, a lot of increased drive, disinhibition. They do things recklessly in a way in which they would not do. Their judgment goes to the winds. They're fearless, which is a tremendous aspect of certain kinds of creativity, certain kind of courage and recklessness, both. And they're grandiose. And one of the things that's quite wonderful about mania, in looking way back to the ancients, is this kind of sense of grandiosity, of thinking of things on a vast scale, not thinking this kind of manicured lawn kind of thinking, but really taking things on. But I think people who have been depressed, and if you interview artists and writers, they would say about depression that there is something to be gained as well, that suffering is integral to the human condition. And if you're a writer or a painter or a composer, that's what your job is to go out to the edge to express those things of the human condition. There's a tendency when you are depressed, whether you want to or not, to deal inwardly, to think why of what avail, to think about death, to think about all those things we just as soon not think about. There's less in denial. And likewise, I think with many writers, it's like when you're manic, you generate a lot of things, a lot of ideas, a lot of projects, a lot of schemes, most of which are pretty terrible. But some of them may work, and what you find in a lot of writers, and Robert Lowell's a great example of this, is when he was manic, he would be on the wards either writing new poetry himself or saying that he was John Milton and changing Milton's writing around, or that he was T.S. Eliot, who was his mentor, and he would take out every other line of T.S. Eliot. But when he got depressed, he would then edit down what he had written. He got very ruminative, obsessive, and critical. And those things are, of course, terribly important in getting work out. And then finally, just one word on treatment. The question always comes up, and I use this as a slide in teaching. There's a great cartoon from the New Yorker that shows Edgar Allan Poe in the background and the raven in the foreground. And he's got a sappy smile on his face. Nothing, Raven. Edgar Allan Poe has a sappy smile on his face. And he's saying, "Hello, Birdie." And this is the caption is if they had had Prozac in the 19th century. So the question always is, what would happen to creativity, to imagination, to drive, to this recklessness if you treat it? And I think that it's not nearly as well studied as it should be. There are a couple studies showing that people who are on lithium who say that they are as productive or more productive on lithium because these are illnesses that not only are devastating, but they last a long time. And they cut into people's lives terribly. These are illnesses that are treated by drugs that affect the brain, and it's not a benign thing. I mean, there are side effects and there are questions. But I think that what you want to do is give people options. And in this day and age, we have wonderful options, and the evidence is certainly on the side of treatment. So I'll leave with a quote from Robert Lowell, who spanned the treatment span. When he first got sick and was first hospitalized in 1949 for acute mania, there was only electroshock therapy. I say only, it was a very good treatment, but that was the only treatment that was available to him. Then he was treated with Thorazine, and then he was in the very early uses of lithium, which changed his life around. And for the first time in 19 years, he wasn't in a hospital. And so what he said is about lithium, "These pills for my manic seizures seem to have made a cure, though I will take them to my dying. This has changed my life. Not only no attacks, no hospitals, but even, and perhaps most importantly, health itself is different, freer, and out of the shadows." Thank you.
Thank you, Kay. I often forget until I hear you again that not only do you have this fantastic capacity for expressing and describing your experience, but you've maintained such a great sense of humor about it. I think it's really a saving grace. Amy Morrow. I first met Amy at the first Chicago briefing that I attended. I've heard her tell her story to a small group, and now I can't wait to hear her tell her story to all of you.
Thank you, Joyce and Dusty and the Foundation, for asking me here to tell my family story. It is an honor for me to be on this panel with these amazing experts in the field of bipolar disorder. My name is Amy Morrow. I am a mother of 3 adult children, one who has bipolar disorder. The story I am about to tell is with the permission of each and every member of my family. 8 years ago, almost to the day, I woke up to several messages on my phone from my youngest son, Will, who had just returned a week earlier to Boston College after winter break. These messages were only 2 or 3 words long, and none of them made any sense. I called Southwest Airlines, and I called my brother Jim, who lives in Portland, Maine, and has many years of sobriety. He picked me up at the Manchester airport 3 hours later, and we headed straight for BC, thinking we were on our way to an alcohol-drug intervention. After 30 seconds with Will, it was apparent this was not the case. With a recommendation from a doctor at the counseling center, who offered to have the campus police help if needed, we were on our way to the hospital. Despite being pre-admitted, we spent 6 hours in the ER. During that time, we learned from Will's roommate and friend, George, that Will had not attended classes or slept since he had returned to school. Will was extremely agitated. Trying to make sense of what he was talking about was impossible. It was scary and exhausting. Finally, a bed was ready, and Will was wheeled upstairs, with the staff suggesting I not accompany him. On visiting the hospital the next morning, I understood why. The psych ward did not look any different than the one from the film One Flew Over the Cuckoo's Nest, complete with triple sets of locking doors. We were fortunate in Will's case that a diagnosis of bipolar was straightforward. For many people, especially children, a diagnosis can take years. Will was started on meds in the hospital. During the 3 weeks that Will spent in that place, I received the Save the Date card for the first annual Ryan Licht Bipolar Medical Briefing Luncheon in Chicago. At the time, I didn't have a clue that Dusty and Joyce would become close friends, often knowing what Will was going to do before it happened. They have become my go-to resource and great supporters and real friends of Will's. When I attended the first annual medical briefing luncheon that May with my daughter and husband, we sat in a corner wiping away tears as we began to more fully understand the challenges for Will and our family. My husband Bill and I have 3 wonderful children: Anna, our oldest, James, and my baby Will. Bipolar disorder is a family illness, and such is the stigma of this illness that my husband's first reactions to Will's diagnosis was, quote, he will never graduate from college, have a job, or live on his own. Anna had just graduated from college and was in Chicago recovering from hip surgery when Will became ill. The juxtaposition of our ability to operate and fix Anna's labral tear was in stark contrast to our options for treating Will. While stable enough to fly home to Chicago from Boston, Will was still very sick. Whenever his doctor tried to reduce the handful of horse pills that Will took nightly, he showed signs of mania. Our insurance paid over $100,000 for Will's 3 weeks in that hospital, but covered very little of the weekly psychopharmacologist visits or the medicines to keep my son stable. Living with Will when he returned to Chicago that spring, Anna was the first to identify that Will's meds were not working and that he was losing touch with reality. The first of many relapses, despite Will's complete compliance in taking his meds. Finding the right combination of drugs to treat an individual's illness is wizardry, and we are blessed to have a talented sorcerer on our team. James, our oldest son and middle child, is a very handsome and smart young man. Entrepreneurial, having started a successful kayak business on the Chicago River, he is outwardly sure of himself. But when I asked him to tell me how he felt about Will's illness, he was not able to express his feelings. Thinking about what I wanted to share with you today made me more aware of the issues James faces in dealing with his brother's illness. Will's progress was uneven. First diagnosed in 2007, it took Will, who had graduated with honors from high school, 3 additional years to finish college, often only able to carry a course or 2 at a time. Boston College was incredibly supportive, actively assisting Will in every way they were able, and I hold the school in high regard for their help and compassion. Following Will's graduation in 2010, he focused on a career in golf. Because the lithium shakes ruined his putting, he decided to look towards golf course management, starting in maintenance. In 2012, Will had another psychotic break and ended up at home, basically in bed for almost a year, going days and sometimes weeks without a shower. It was our son James in May of 2013 who got Will out of bed, made him take a shower, shave, put on clean clothes, and with resume in hand, drove Will to the golf course to apply for another job in golf course maintenance. Will spent the summer of 2013 getting up at 4 a.m. to mow greens, cut cups, and fill sand traps 6 days a week. He stuck out the entire summer with a boss that made his life miserable, a boss who could not understand why someone who had graduated from Boston College could not make change in the pro shop. Will never missed a day of work or told his boss about his illness. That summer, Will paced and paced. What should I do with my life? He asked over and over. Not an uncommon question from a recent college grad. His mood swings, however, continued, as did his irritability. It was hard for our family to deal with. We felt like we were walking on eggshells. To friends, I sometimes joked I was running a psych ward. At home, I drank every night to escape my new life. For the past year, Will has been working in a job that he loves, editing professional and college sports games for internet content, a job that found him via a neighbor who likes Will's sense of humor and asked him for his resume. Will lives with 3 friends from work, but he doesn't want them to know about his illness, having learned from experience about the stigma of bipolar. His job includes medical insurance, paid vacation, and life insurance. I hope never to collect on that life insurance. Will has always taken his meds. With a twinkle in his eye, he said he liked the mania, although he didn't remember much of what happened during his manic episodes. He takes his meds, quote, because he says the period of recovery from mania is awful. He recently told me that he spent that year in bed because with his mind racing, getting out of bed to do anything seemed impossible. This past October, Will was able to understand that he was becoming unstable, and with help from his doctor and an extra day off of work, he averted a meltdown. Real progress. When I asked Will what I should add to these remarks, he said, "I wouldn't be where I am today without the full support of everyone in my family and my good friends." Our family story is not unique. It is a story of love and determination. I am the mother of 3 wonderful children, one with bipolar disorder, and I'm a person filled with a realistic hope that through research, tomorrow will be better. The more we can learn about the brain, the more we can understand why people are held hostage by illnesses of the brain, the more we will be able to help others lead a normal and productive life. It has been a privilege for me to speak to you today, and I thank you for your support of the Ryan Licht Bipolar Foundation. By being here, you are helping to erase the stigma of bipolar disorder and making a difference for so many.
Thank you, Amy. I think you can tell how much that was appreciated. So we have time for some questions. There are people out in the audience with microphones. If you would like to address a question to any of the panel members, please just raise your hand and someone will come to you with a microphone. Someone right up front here.
Thank you, panel. It's an inspiration to all of us. I would like to know what role marijuana plays in the treatment or non-treatment of bipolar versus standard medication, or are doctors in agreement on the treatment with marijuana?
So Karen, I think this one's for you. The only MD on the panel, I think this one's for you.
I think there's strong agreement among treatment providers that marijuana can be devastating for the treatment of bipolar disorder, that it's very destabilizing for the brain, and it actually interferes with the other treatments working. What I can tell you is that many young people escape their experiences and the challenges of how they feel when they're either depressed or manic by using marijuana. And so there's no doubt that it's bad for the brain. And I'm saying that as a physician, not as the police or a moralistic person, but it's bad for the brain. Unfortunately, its role in what people refer to as self-medication. I don't feel good, I want to change how I feel. If I'm high, I don't feel the same. Means that it's a great challenge for us because young people are using it, and it's terrible and devastating sometimes.
I think one of the things that we've missed until more recently is how much anxiety is associated with bipolar illness. We thought of anxiety as being associated with unipolar depression and not so much with bipolar disorder. But unfortunately, marijuana is just a fantastic anti-anxiety agent. And that's why young people with bipolar, I think that's why they're so attracted to marijuana. But as Karen said, the consequences of marijuana use there is nothing good about that for bipolar disorder. Other questions, comments? Yes.
Hello, and doctors, you were absolutely superb, and thank you so much for being here. I think the Sang family is amazing, and what they've also done the last 10 years by the quality and the top of the profession coming in here. Dr. Buckner, I just left MGH yesterday. I'm a Bostonian, and my family has been going there for years, and they saved once my dad's life and just saved my brother's, so thank you for being here. I have a lot of knowledge about bipolar disease, and I have a few quick questions. I'll try to blend them together. Maybe I'll list them, and you can all answer me in one or two ways. I'd like to know early onset of eating disorders that start in typically young women. There's really no cure for it yet, and a lot of people really don't understand why it's happening. And if you think about an eating disorder, when they're happy, they're manic. And when they're angry because they put on weight, they're depressed. So maybe there's something in the areas of the brain that coordinate. I also am very confused about how people define bipolar 1 and bipolar 2. I happen to know people...
Let's take these one at
Oh,
a time.
okay, I'm sorry.
These are excellent questions, but I
Okay.
think it may be hard for
Well,
everyone
they
to...
can just go with those.
Okay.
I'm sorry,
All
thank
right,
you.
so let's start with the bipolar 1, bipolar 2 question. Who wants to take that one up? Okay.
Bipolar 1 is the classic notion of manic depressive illness where if you conceptualize severity of mania, say, as +3 on a scale and really severe depression is -3, traditionally bipolar 1 has meant kind of going from +3 to -3, not always true, but you have a history of full-blown mania along with a history of depression. Bipolar 2 is a much more controversial and, as some of us would say, overused diagnosis that, depending on if you're European, you might have a broader definition of it, an American, less broad definition of it, but it's generally a milder form, but it often has very severe consequences in terms of suicide and in terms of substance abuse. But by and large, the symptoms of mania are not as pronounced, and people don't tend to end up in the hospitals in the same way, and they are not as severely ill acutely. But one of the problems with bipolar 2 is a lot of people don't get sick enough. I mean, I've always regarded, I have bipolar 1, a severe form of it, that one of the great advantages of being flamingly psychotically manic was I didn't have any choice but to get treatment. If you've got bipolar 2, it's much easier to just associate that as a temperamental part of your own personality, part of the, whys and wherefores of life. So it tends to be a less treated condition. But as I say, depending on who diagnoses it, the Europeans very often will not have as long a duration requirement as Americans will, and so forth.
So Karen, do you want to add anything to that?
No, I think you.
I think the one thing, though, that we sometimes miss about bipolar 2 disorder is how much suffering is associated with the depressive part of bipolar 2 disorder. So it can be, in some respects, as impairing. Definitely not as dramatic as bipolar 1, classic manic depressive illness, but just as impairing in terms of how much time people spend in depression. Now, the eating disorders question. What do we think about a relationship between eating pathology and bipolar disorder?
Well, I started my career also working on the eating disorders unit at Hopkins because so many of the young women on our unit also had mood disorders. And I was interested in mood disorders in women, so my boss sent me there. And what I can tell you is that there are two separate things. There are a group of mainly women, but also young men, who have eating disorders, who certainly have intense emotions, where they get very upset when they are at a weight they don't enjoy versus when they're thinner. But then there's another group where they have the challenge of having both an eating disorder and a mood disorder. And that is the group that tends to have the roughest time, the hardest time making progress, and the hardest time getting well. Because one often masks. You're so caught up in someone having lost weight that you're missing the depression, you're missing the mania. And so I think we have to know that. And among those who have the most severe forms of eating disorder, some studies have shown up to 80% also have severe depression or anxiety.
So we're getting close to 1:30. Perhaps we'll take one more question in the back there. Yes.
Great, thank you. As a psychologist and a brother of someone who has bipolar disorder, I am so honored to be here and thank the foundation and the presenters for being here. It's absolutely amazing. With regard to early intervention, without ready access to imaging technology and until the research catches up, how would you suggest we best go about diagnosing and not overdiagnosing or improperly medicating our children?
It's up to you, Karen.
Well, I would say that you start with an evaluation with someone you trust. And with early onset, you often need an excellent child psychiatrist, because with really little children, you have to use observation and information from families in a different way. If someone's an articulate high school student, you can engage them, they can describe their own experiences. And so our challenge is that right now it's a clinical diagnosis, so you try to get the most experienced clinician you can find to weigh in. And I think what we have to do is balance everyone's worry about not wanting young people on medicine they don't need versus having someone be ill and having it interrupt and negatively impact their life for a number of years. So that's what I would suggest.
And particularly those developmental years that are hard to recapture. If you miss the years between 28 and 32, it doesn't have the same consequences as missing the years between 14 and 18. So I think on that note, I will say thank you to all of you for your time, your attention. You could have heard a pin drop in this room throughout the entire series of talks. Those of you who would like to stay on for a few more minutes, we welcome your questions. Those of you who have other obligations, please feel free to quietly get up and leave. Thank you.
My question is, how can we get this population to adhere to their medication regime? Because frequently I found that obviously when they feel better, they'll stop taking their medicine, which of course is a predecessor to either a manic or depressive episode.
Okay, you have a few thoughts about that?
Actually, one of the reasons I wrote An Unquiet Mind was that was a particular journey I took a few too many times of not taking my medication and with nearly lethal consequences, and catastrophic, and I really didn't want other people to have to go through. I would say that's the most frequently asked clinical question, and it is the major clinical problem in treating bipolar illness. The major clinical problem is not that we don't have treatments. The major clinical problem is that once people are in treatment, they don't stay on treatment, particularly people who are young. My personal sense is that some combination that, first of all, is impossibly hard. Secondly, a lot of people are just not going to do it. You can't, in teaching the residents, I show them a slide of after the anthrax scare in Washington and the Eastern Seaboard after 9/11. I live in Washington, and we had a sniper, we had the Pentagon had been bombed, and we had anthrax. Under those circumstances, when everybody's on high alert, they got free antibiotics. Anybody who was exposed, they got free antibiotics. They got public support. They got public health backup. Under those and in a pretty educated city, contrary to what you might think, the adherence rate was about 60%. This was for 3 weeks. What we're asking adolescents to do is take drugs that have very serious side effects, weight gain, cognitive slowing, all sorts of things. We're asking them to take them, and if the drugs work, there's no motivation to take them because people feel well. So it is a very, very hard thing to do. My personal sense is that if people really knew a little bit more about the dangers of stopping medication, including increased risk of suicide following the cessation of lithium, but if people knew a little bit more and knew some of the neuroprotective literature, when I stopped taking lithium, I didn't know, nobody knew, that this was actually doing good things for the brain. I mean, the assumption was that the best you could hope for was that it would stop your illness from coming back, and since you didn't believe your illness was going to come back anyway, it didn't make any difference. What we know now from a lot of very interesting studies is that there are actually neuroprotective effects of some of these major medications, perhaps particularly lithium. And so I think people knowing that, including some of the people I was talking about, like the writers and so forth, if they knew their brain was being compromised by the disease and saw some of the scans that show, this is your brain on 1 manic episode and this is your brain on 8 manic episodes, that people would take this illness a little bit more seriously. But we don't have clinicians that know these things. We don't have a visual backup kit. I would love to have a visual backup kit that said, this is what your brain looks like, and this is what you can do to protect your brain. That's not going to keep everybody on it. What you can do is try and have support groups. You can try and do all sorts of things. Psychotherapy. certainly can increase adherence in some people. It's a little equivocal, but it's as good a shot as we have at the moment is adjunctive psychotherapy, which unfortunately insurance companies don't tend to cover.
Amy wants to add something.
Is this working? Can you hear me? At one point, my son, who's on, has had a different groups of medicines that have been working, and he's on a group now of Depakote, lithium, and Zyprexa as needed, said that he felt just like he did when he smoked marijuana. So the drug combination for him actually is a positive feeling.
And I think there's one thing I would add to that. I believe that we clinicians are partly responsible, and that is that we're so terrified of the manias that we put such a lid on the low-level, pleasurable, positive aspects of mania. We use the medication as almost a straitjacket. And if we had the confidence in our patients, and one has to develop that confidence through a long-term relationship, to let them be just a little more happy, that I think this would be less of an issue.
No, I think that's very true, and it's particularly true with, a lot of my patients who are writers and artists, and I think that people are willing to take risks if they feel like they are going to get something out of it, which is namely a certain amount of liveliness they would not otherwise have. Karen and I have one of our colleagues at Hopkins, Adam Kaplan, who's worked out a system for being mood ratings every day so that you can track people's moods. And to the extent that you can engage people in their own treatment and can learn that, okay, there are these cycles, whether they're menstrual cycles, whether they're seasonal cycles, whether they're whatever kind of cycles, or there's a response to a particular kind of life event, that you can get people engaged in their treatment and believing that they have some sort of impact on the outcome of their treatment. I think that can be a very good thing.
Yes, back there.
Yes, hi, thank you. The panel was exceptional. I really appreciate being here today. I'd like any thoughts for any new medications that are showing promise for bipolar 1 with mania, apart from the staple of lithium. Any thoughts?
Karen?
Well, with lithium, it's still the best. And I just reviewed the literature on this. It's old and it's still the best. There are a number of other anticonvulsants or medicines usually used to treat seizure disorders that are being explored. I think with a lot of them, when they're new, we don't quite know how to dose them yet, and we don't know how to optimally use them. And so the exciting thing is that a number of options are there, and we'll learn more about them, I think, in the next 5 or 10 years to use them better. But there's no doubt, if you look at the data, lithium is still the best. In the United States, marketing has taken over and lithium is used less. In Europe and in some of the Scandinavian countries where every single person is part of a registry, they can look at long-term outcomes and they're much better with lithium. And so while it's exciting because some people don't do well on lithium or don't tolerate it, to have other options, I want to put a plug in for a very old medicine.
And also a very powerful anti-suicide effect. That there are 25 or 30 studies that show that lithium very much decreases suicide risk.
So one last, Sally, I think we'll let you have the last word, but you have to wait for the microphone. I'm sorry, just like everyone else.
I want to know what the patient who is taking the lithium, why they say they want to get off of it. What happens to them?
Well, let me count the ways. Lithium has very real side effects. I'm a huge fan of lithium. Lithium saved my life for decades. It has side effects. All of these drugs do. All of the drugs that affect the brain have significant side effects. So, weight gain. I think the one that probably is much more powerfully important to most people is it has, in higher doses, has a very real effect on your capacity to think clearly, quickly, to process information. So that what we know from a lot of studies, and one of the great things about the fact that science and medicine move on, is that when I was first prescribed it, which was not that long after lithium was first approved by the FDA, people were kept at very high levels. So, I literally was walking into walls, vomiting, spending a good chunk of my life in the emergency room, getting IV drips. because that was what was necessary to control my illness, and that was what was thought necessary to treat my illness. What happens now is people are kept at very much lower lithium levels, and the side effects are, as a result, much less significant. But, you know, if you're asking somebody who's athletic, 19 years old, loves sports, and they're going to have possible skin consequences, possible cognitive consequences, possible energy consequences, possible coordination consequences, this is not an easy sell. I mean, I don't think we can in any way deny it. It doesn't mean it's not an important sell. And a lot of things, my husband's a cardiologist, and he's always saying, you know, look, you guys go on nattering on all the time in psychiatry about adherence. Try being a cardiologist and getting people to stay on a diet or exercise or stay on their statins or whatever. You know, it's not a problem that's unique to psychiatry. It's a problem that's just part of the human condition. We don't like to acknowledge that we're sick or that we have an illness that could be severe and come back. You know, denial is a great thing. It gets you out of bed in the morning, but it's not very helpful in terms of adherence.
Excellent. So let's conclude this medical briefing by thanking Joyce and Dusty Sang for their incredible energy, courage, and grand style.